Okay, the other type of disorder, respiratory disorder, I'll talk about is restrictive kind of respiratory disorder. Again, I'm just going to use one example just to give the idea and the concept behind this kind of disorders. The more serious respiratory or restrictive disorder will be discussed in critical care. But now I'm just going to give you an idea of what could happen regardless of the kind of respiratory disorder and how that restriction, what does it cause. So the example will talk about the pleural effusion. Now, pleural effusion by definition is an abnormal collection of fluids in the pleural space. Now, remember that we have the lungs, and they are surrounded by a visceral pleural cavity, and then surrounded by the pleural cavity. Sorry, in the pleural cavity, there's a small amount of fluids, serous fluids. Its major function is to prevent the friction between the lungs and the inside of the pleura. Now, for some reason, these fluids become accumulates, and normally it's like 5 to 10 only. Now, when it accumulates, it will of course leave less space for the lungs, as you see here. So the lung will not expand. Of course, when the lungs is not fully expanding, the amount of air that will enter the lungs for the gas exchange will be limited, and as a result of that, the gas exchange will be impaired. So this is the whole idea behind it. So whether it's cirrhosis, whether it's infection, regardless of the type, it's the same idea. It's restricting the lungs from expanding and doing enough gas exchange. Now, in case of pulmonary pleural effusion, it could be transudates, and this is like pretty much like edema. It has to do with the filtration, has to do with the concentration of the difference in concentration between the blood and the cells. So you will see it in chronic disease like congestive heart failure, cirrhosis, renal disease. It has to do with the fluids issues. The exudates, on the other side, it's more of inflammation as a result of some kind of infections or maybe cancer. Regardless, again, of the type, it's the same idea. It's less room for the lungs to expand. Now, the clinical manifestation as a result of that, as you know, think about it, again, you have less expansion, less gas exchange, so there will be hypoxia, and the patient may show symptoms of dyspnea. Now, the symptoms that the patient may show depends on the amount of the pleural effusion. Sometimes it's minor, to the point that the patient does not show any kind of symptoms. If it's significant, the patient will be in severe dyspnea and so on. But that is the major classical or the classical manifestations in this case. Now, the other thing is if the fluid is more of a is more of a result of infection and inflammation, so the patient may show some symptoms of infection as a result of that. Now, the management of this condition is basically to get rid of these fluids, and we do that by aspiration. I will show you the procedure now. Now, as far as physical examination, there are some classical symptoms in this patient. Again, the patient may be asymptomatic if the amount is small, but as you see, because of the air, the air or the volume of air will be diminished, so we expect that the breathing sound will be also diminished or even absent. And the other thing is when the lungs try to expand, and if there will be some friction between the lungs and this fluid, so that's what we call it pleural friction rubs. And from the name, it's plural, so it has to do really with the pleural. So this is the classical symptoms. You only see it in the pleural effusion. Also, remember from percussion that when you percuss an organ that is filled with water or is surrounded by water or fluids, it will give you a dullness sound. You know that normally the lungs, they do resonance, right? So in this case, you will see more of dullness. So let's hear how it sounds to have a diminished harsh breathing sound. And this is how the pleural rub sounds. Okay, now let's see the procedure of removing the fluid from the pleural space. And that's the first thing, is that we need to confirm that by doing a chest x-ray. We talk about the idea of chest x-ray. As you see, there's a fluid surrounding the pleural cavity, and of course we will need to know the history of the patient to confirm is this is more of infiltration, is it an infection, or is more of pleural effusion. But the chest X-ray will show the pleural effusion, and then under guidance of CT scan or ultrasound, we can insert a needle and get rid of this fluids.